Director at SHARE.
Hi, everyone. Before we start the program, we would like to make you aware that we will be live streaming the program to Facebook. Please take this time to turn off your videos for anonymity. All participants will be muted during the program. You are welcome to submit questions during the presentation through the chat feature at the bottom of your screen. When asking questions, remember that the presenter is unable to give specific medical advice, so please keep your questions general in nature.
We'd also like to tell you a little bit about SHARE. SHARE is a nonprofit organization that has been helping people through breast, ovarian, uterine, or metastatic breast cancer for the last 44 years by offering the support of those who have been there. SHARE provides many services, including a helpline, support groups, and educational programs like this. All of our services are free of charge to participants. For more information, visit our website at sharecancersupport.org. This program is being recorded and will be available on the SHARE website soon. It will also be available for viewing afterwards on Facebook since we're streaming live.
Now I'd like to introduce today's speaker. We're very pleased to welcome Dr. Kevin Holcomb. He's an associate professor of clinical obstetrics and gynecology at the Weill Cornell Medical College, where he also serves as the vice chairman of gynecology and the director of gynecologic oncology. He was recently also appointed associate dean of admissions at Weill Cornell. Dr. Holcomb has contributed over 90 publications to the peer-reviewed literature and combines his research interests with a clinical practice focused on respecting the individuality of each patient and personalized care. Thanks so much for joining us, Dr. Holcomb, and we'll turn it over to you.
Thanks so much, Kitty. And thank you to SHARE for the opportunity to address your community on such a timely topic. And I know a lot of my patients are very concerned about COVID and its impact on their treatment. So I think it's a great opportunity to reach outside larger than just my practice to be able to bring some information to your membership. I'm going to share my screen if I can do this without messing it up. Let's see. Okay. Okay, can everyone see my screen?
Yes.
Great.
Yeah, we see your presentation.
So I'm going to start off just by giving a timeline of how quickly things evolved in the New York City pandemic. And, you know, to say, unfortunately, while we're watching this pandemic unfold nationally, right now, one of the best places to get information on COVID comes from New York City, because we were the first epicenter of the pandemic, unfortunately. And this timeline shows you how quickly things happened. We had our first case in the United States on March 1st, a woman returning from Iran. By the second day, the next day, we had a case in New York that not only was our second case, but proved that there could be community spread. What was concerning about this was an attorney from Westchester, works in New York City. Infection spread to about 50 others who worked at the same office. In less than a week, there was a declared state of emergency in New York. And at that point, we had only 100 cases, but social distancing was put in place. By a week later, we had public schools closed. New York State was put on pause by 3/22/20 with over 10,000 cases and 99 deaths. And I think the biggest impact on medical care happened on the 23rd of March. And that's when the governor placed an executive order stopping all elective surgery to maximize hospital beds. Obviously a step that was required given what was going on. By 2 days later, the governor's on TV pleading for PPE because of the critical shortages where there weren't even enough masks for healthcare providers. The plateau begins by April 8th. We had about 76,000 cases in the state, and unfortunately, we were up to about 800 deaths per day at that point. And by April 15th, we had over 120,000 cases and 11,000 deaths from coronavirus and COVID-19 in New York State. But again, it was really the first big impact of medical care was on 323, where thousands of patients who are typically diagnosed per year with cancer and ongoing treatment for cancer were impacted by this decision to stop elective surgery. Rapidly, there were changes that were brought about. As a physician in New York City dealing with this pandemic, I can tell you there was a real change in your perspective about caring for your patients. Many of us were being redeployed to ICUs to fight the COVID pandemic. We had little reliable data on the risk we were taking personally, the risk we were potentially putting our patients in. There were rapidly changing regulations from the New York State Department of Health telling us how many patients we could see in our offices, what type of things we had to have in place to be able to do so. And then you had some variation in the institutional responses. Certain hospitals were making changes that others weren't. Our patients had just as much of a change in their perspective. What was interesting was this uncertainty about what their biggest threat was. What should they fear more, cancer or COVID-19? And I'll show you some data that we collected from New York City survivors who were very clear about what they were concerned with. There were lags in communication and limited resources for information for patients. And so the central question for a lot of patients was, well, does my having cancer or being treated for cancer actually increase my chances of having a bad outcome from COVID-19 if I get it? Am I more likely to get it? And if I get it, am I more likely to have a bad outcome? And the only data that we had came from the experience in China. There was a publication in the Journal of the American Medical Association in March of 2020, fairly large with 1,500 plus patients, but I'll mention that there were no GYN oncology patients in this cohort. And they did see that patients did worse there. The infection rate in the cancer patients was double what you saw in the background population. But there are some big differences in what was going on in Wuhan. In Wuhan, the hospital was a major source of infection itself. While there was community spread in that cohort, greater than 41% of infections came from the hospital itself. And cancer patients in that study had significantly increased risk of being intubated, going to the ICU, and dying of the infection. And our understanding of the chances of a bad outcome from COVID-19 infection started to come together. This is a comprehensive review that was published in May of 2020. And one of the things we learned is how COVID gets into the body is through a receptor on the surface of tissues, mainly respiratory tissues and some in the nasopharynx and places like the kidneys, called angiotensin converting enzyme, or ACE2. And what we started seeing in this picture was that certain age groups had low ACE2 expression on their tissues, for example, children and adolescents and young adults. They also have a strong immune profile, and they tend not to have many medical comorbidities. They had very little risk of getting significant COVID-19 infections. When you look at middle-aged people, you see an increased risk, an increased expression of ACE2 on their tissues, so more opportunity for the virus to get in. They tend to have a sufficient immune profile, but may have a few comorbidities. And so you see in the 40s, usually low COVID-19 significant infection rates, and then you start seeing the numbers going up for the elderly, where there is a much higher expression of ACE2 on their tissues. And they tend to have a weaker immune profile and much more likely to have multiple comorbidities, including cancer. And so this picture that ACE2 expression and immunosuppression may come together to help determine your likelihood of getting a significant COVID-19 infection. As physicians treating cancer, we didn't have a lot of guidance on how we should change our practice for delivering cancer care, but a few things started coming out. This comprehensive review offered a broad guideline of how we should be looking at cancer treatment and suggested that oncologists should prioritize who we were treating based on the likely outcome of that treatment. And so women or men who had rapidly progressive tumors, who had an increased mortality risk, those who had urgent surgical oncology needs, who were getting definitive curative treatment should be prioritized. The next group down in priority would be those who had stable tumors but required adjuvant therapy. So maybe somebody who had a complete surgical debulking and was getting adjuvant therapy would be put in that priority B. Or a palliative therapy, but one that had a survival benefit. And then priority C would be palliative treatments with no significant survival benefit, routine cancer screenings, palliative treatment to prevent morbidity, and definitely things like cancer genetics, which are, genetic testing is hugely important, but in the face of a pandemic, those would be the type of visits that you could put at a lower priority. Specific to GYN oncology, SGO was very helpful in stepping in, the Society of GYN Oncology, and offering us these specific guidelines. And a similar idea that the goals of therapy need to be used to prioritize patients. So those being treated with curative intent would be prioritized. For example, now we know in ovarian cancer, there's benefit to maintenance therapy. PARP inhibitors are being used as maintenance therapy, but they suggested that we should be even prioritizing further there, stratifying patients by who has the best chance of seeing a benefit of maintenance therapy. For example, a patient with a BRCA mutation is known to have a better response than someone who has, a homologous recombination proficient tumor. And those who are being treated with palliative therapy, we should be prioritizing by how likely that treatment was to result in relief of uncontrolled symptoms. But what was really important is that we needed to individualize this treatment based on the COVID-19 burden in the area. Because what we were learning at the same time as this information was coming out was that there were disparities in who was facing COVID-19. Not just ethnic disparities, but disparities also based on zip codes. And sometimes they were tied together and sometimes not. If you look in New York City, what you see is that Queens actually had the highest burden for COVID-19 infections, followed by Brooklyn, and the Bronx was actually highest, followed by Queens, Brooklyn, and Manhattan actually had relatively the lowest COVID-19 burden. And keep that in mind. I want to show you some data that we collected from our patient populations that really show that the impact was differential based on the borough you lived in. SGO said there should be some general considerations that are just common sense things. Temperature and symptom screening is not great, but it is important. Obviously, people should not be coming to your office who have fevers and symptoms of COVID-19 infection. If available, because at this point treatment testing wasn't widely available, it was recommended that you should test prior to treatment. I know at New York Presbyterian, we had to establish a specific treatment area. It was in a tent outside the hospital for our patients to go get tested before they went for chemotherapy. We should utilize telemedicine wherever possible to decrease the need of patients to come into the hospital. That we should collect labs locally whenever possible for the same reason. That oral regimens should be prioritized over intravenous regimens. All of these things, the same concept, keep people out of the hospital wherever possible. If you could find a regimen with less frequent dosing, you should take advantage of it. And one of the things that we did was patients on immunotherapy, for example, getting pembrolizumab or Keytruda. Typically, we were giving it to them at 200 milligrams every 3 weeks. Merck came out with a guidance saying you can give our drug to 400 milligrams every 6 weeks. And so we transitioned patients to alternative regimens that were more spread out. To keep patients out of the hospitals, based on that Wuhan data saying the hospital was a big site of infection, we were recommending using infusion suites outside of hospitals. And for us, it was easy. Our infusion suite was in an ambulatory care setting, so there wasn't a big change for us. And to delay non-critical imaging. Many patients are getting follow-up CAT scans and PET scans, and to be honest, it's a lot of this surveillance therapy. We don't have good evidence showing that it's a benefit. And for those things without a proven benefit, we were recommending that you delay those things. I would say for ovarian cancer patients, the biggest change that I saw in my own patient population and those that I saw as second opinions was an increased use of neoadjuvant chemotherapy. And for those, I'm sure this crowd is very familiar with this argument, but the traditional treatment scenario for someone with advanced ovarian cancer would be option number one that you can see here, where patient undergoes surgery, a debulking surgery, and then 6 cycles of adjuvant chemotherapy. What's raged on is this debate of the appropriateness of option number 2, which is not to do surgery up front, but to give 3 cycles of chemotherapy, surgery sandwiched in between, and then the final 3 cycles. And there have been a number of randomized prospective studies coming to the same conclusion that giving chemo first is non-inferior to upfront debulking. Well, but what had been shown is that giving chemo first led to less aggressive surgical debulkings and less time in the hospital and less likelihood for a bowel resection and lower complication rates. So neoadjuvant chemotherapy was a much more attractive option in the middle of the pandemic. But what I saw pushed even further is this idea that you should intervene with surgery after just 3 cycles of chemotherapy. For many patients, that 3rd cycle came and it was in the height of the pandemic. So the decision was made to go ahead and complete all 6 cycles up front and give the surgical debulking at the end. And I think that is something that was a big change in treatment patterns during the pandemic. Other things that happened with ovarian cancer patients is that we were guided by the SGO that we should really avoid things that kept you in the hospital longer or brought you to the hospital more frequently. Weekly dosing schedules, like dose-dense regimens. They had already been challenged in the most recent GOG frontline trial, the prospective frontline trials in ovarian cancer had already shown that some of these regimens were no better than every 3-week dosing. So we were recommended to avoid those. HIPEC stands for hyperthermic intraperitoneal chemotherapy. It's a situation where after the debulking chemotherapy is put right into the belly and heated up, patients tended to stay in the hospital longer with those therapies, had higher risk of bowel complications. So we were recommended to avoid that. And intraperitoneal chemotherapy for the same reasons. Some of you may be aware that while most ovarian cancers are high-grade ovarian cancers, serous being the most common, where adjuvant therapy is chemo, when it comes to low-grade serous carcinoma, we're starting to recognize that that's a whole nother animal and doesn't respond to chemotherapy that well. And newer studies are suggesting that hormonal therapy might be more appropriate. And that's often given as oral. So it became more attractive to give low-grade serous patients oral therapies. Endometrial cancers, we saw some treatment changes there. For patients who have low-grade endometrial cancers, we've known for years that you can cure a portion of those patients by treating them with hormones, either intrauterine with an IUD or orally. And so someone diagnosed with a low-grade endometrial cancer, you could stay off their surgery, their definitive hysterectomy, if it's in the middle of the height of the pandemic, by giving them an IUD, and we did that with a number of patients. For recurrent uterine cancer patients, where there was a choice between a hormonal approach and chemotherapy, when appropriate, we would bend towards the hormonal approach. And if there was a hormonal combination therapy, for example, a combination called Afinitor and Letrozole, there's more immunosuppression. You question whether that was the way to go at the time of the pandemic. I already mentioned the immunotherapy change of less frequent dosing for Keytruda. For cervical cancer patients, we're recommended to avoid radiation unless there was a curative intent. So, you know, if you were giving somebody upfront radiation for a curable, locally advanced cervical cancer, you should go forward. If somebody had a recurrence of ovarian cancer and had gotten cisplatin in the past, you can get through a carboplatin-based regimen faster because it's a shorter infusion protocol, and it's been shown to be equivalent. And so the recommendation was to swap cisplatin for carboplatin for that reason. As far as surveillance and recurrence, I think this is another area that underwent major changes. For asymptomatic patients, someone who's had ovarian cancer, she's been treated, she's in remission, same thing for a uterine cancer. We felt it was safe to delay routine surveillance visits or to conduct them by telemedicine. For the patient who was asymptomatic, the chances that her physical exam was going to be the thing that helped you find a recurrence was low. We know from our experience that most patients with recurrences unfortunately have symptoms and have findings on physical exam, but it's very rare that a physical exam will be the thing to detect a recurrence in an asymptomatic patient. For those with ovarian cancer, you may be aware that it's unclear whether treating an asymptomatic recurrence actually benefits the patient with regard to survival. And so if you had a recurrence and you were diagnosed and you had no symptoms and it was only an elevating CA-125, you could delay your treatment until after the height of the pandemic, and we have no evidence that that would impact your outcome. If you had symptomatic recurrent disease, consider lower doses to reduce the risk of bone marrow suppression. This is another area where it's evidence-based. You can treat with lower doses without evidence of decreased impact in many situations. And then in each of these situations, the risk and the benefits in the setting of a possible COVID-19 complication had to be taken into account. We had a number of patients who were on clinical trials or were eligible for clinical trials during the height of the pandemic. And fortunately, SGO came through with some broad guidelines that we should use to determine whether to put a patient on a trial in the height of the pandemic. Keeping in mind, patients on trials often have to come in more often than patients who are being treated off trials. They have standard tests that they have to do that wouldn't be done necessarily in just normal clinical care. And we were guided that we should look at studies as being essential, meaning that they have a high potential direct benefit to the research participant. This is a woman who may have fewer options outside of this clinical protocol, or we have a real reason to believe that she's going to benefit, or a tier 2 where there's a moderate potential direct benefit. But then there are these other studies that are observational or behavioral studies, focus groups, retrospective studies, things that may have no direct benefit to the patient, and it's an altruistic thing that the patient is participating. And we really tried not to put patients on trials where they had to come in the hospital for solely altruistic reasons. One of the things I think was a silver lining about the pandemic was that I saw research collaborations that hadn't been in place before. And I was really proud of the New York City medical community to see how many people worked together who hadn't worked together before in the face of this challenge. And this is a publication that came out from New York Presbyterian, where we actually leveraged our 3 affiliate sites, one in Manhattan, New York Presbyterian Queens, and Brooklyn Methodist, to look at how gynecologic oncology care had been impacted by COVID-19 at these 3 hospitals. And I mentioned why. It's because we knew there was a disparity in COVID-19 burden. So we were set up to look at patients in Manhattan at Weill Cornell, New York Presbyterian Queens, and Brooklyn Methodist. This was a prospective registry, and we had this open between March 1st and April 30th. So it was a snapshot at the height of the pandemic on a small time frame. But we had 302 patients across our 3 sites. So it was a small time frame, but a decent number of patients. Not surprisingly, what we found was a significant number of patients had a treatment modification during the first 2 months of the COVID-19 pandemic. Almost 40% of our patients had some change in their therapy. The majority of them, at least I should say, the most common modification was a planned surgery was changed in some way. 67% of patients scheduled for surgery experienced some sort of related change in their surgical plan. 22% of patients scheduled for medical cancer treatment experienced some related change in their medical plan, and 18% of patients with radiation. And looking back at this data, it makes sense to me because what was really driving things here at the height of the pandemic was the availability of PPE. Anything that required more PPE was going to lead to a higher chance of being delayed. There are a lot of chemotherapies where you have to wear PPE. as the nurses who are delivering it, the pharmacists who are preparing it. But then there's a lot of medications, hormonal therapies, targeted therapies, biologics, where you don't have to wear PPE, and those things were less likely to be impacted. Same thing for radiation. And so it's not surprising when you see surgery having the biggest impact. And what we also were able to see is that, just like that map shows, the chances of you having a treatment modification had to do with where you lived. Much more likely if you lived in Queens, less likely if you lived in Brooklyn, and the least likely if you lived in Manhattan. And I think that this is, as we look towards the future, not knowing where this pandemic is going, this is informative to know that we have to rush resources to places that have higher burden earlier. I think this gives us some idea how to plan better for the future. Another area that I was really happy to see was how quickly this research collaboration came together. This paper that evaluated not just did not evaluate just the impact on the treatment, but how did women cope with ovarian cancer during this height of the pandemic. And this was a great collaboration between Weill Cornell Medicine. Dr. Frey was the PI on this, but Annie Ellis from the Ovarian Cancer Research Alliance, and Cassandra Polite, I hope I'm not mangling her name, from SHARE. And it's amazing what bringing these three together did. They had two validated tools. Validated tools are questionnaires that have been already proven to be able to assess what you think they're assessing. The Cancer Worry Scale and the Hospital Anxiety and Depression Scale were used specifically for this. They collected information through questionnaires on COVID-19 symptoms, diagnosis, treatment interruptions, cancer and health information, demographics, and what people were using as coping strategies. Anybody who's ever tried to do a study knows getting something through an institutional review board that has to approve a study tends to be a slow and tedious process. The IRB approval received in 2 institutions for this study in just 4 days. So these questionnaires were distributed to so many women because it was done through all these different ovarian cancer support groups and social media. And they were able to reach thousands of women really fast and led to 2 publications in high impact journals. And I just want to show you what we found. They were able to get responses from 555 ovarian cancer survivors in 6 countries and 41 states in the US. So I was able to show you what happened in New York City, but this was a really wide ranging view. Similarly, a significant portion reported a delay in cancer care, 33%, about a third. Systemic treatment, chemotherapy, was impacted 8.3% of the patients. Surgical management, again, being much more commonly impacted, 26%. 24% had an oncology appointment changed or canceled. Laboratory tests were changed in 15%. Cancer-related imaging changed in about 10%. What we found was that across the board, there were extremely high levels of cancer worry, seen in 88% of patients. High levels of anxiety in 28%, extremely high levels of anxiety in 23%. Depression was very common. I think this information is also going to be very informative going forward to know what kind of psychological impacts we can expect and how we can target our support services going forward. When we look to see what are the things that drove anxiety, worry, depression, what we found was that, interestingly, variables associated with cancer worry were aged less than 65, being scheduled for cancer treatment, meaning this was a cancer active treatment patient, not somebody with a history of cancer, and being, if you considered yourself immunocompromised. We asked whether patients were self-described, not whether they actually were. Very similar for anxiety and the variables associated with depression. Again, less than 65 years of age, living alone, if they had had a delay in oncology care, and also if they thought they were immunocompromised. The top concerns, if you wondered what were women concerned about, were they more concerned about COVID-19 or cancer? They were more concerned about COVID-19 infection. You can see cancer recurrence was lower, safety of family members, access to cancer care. There were a number of concerns that you can see. It's interesting when you look at how women with ovarian cancer and ovarian cancer survivors, how they reacted to the pandemic with their coping strategies. The coping strategies to the left on this scale are all considered positive coping strategies, while the ones to the right are pathologic or potentially harmful in some of them, like self-blame, behavioral disengagement. And you can see patients coped in a very positive way to this pandemic. And I think that speaks to the resilience of ovarian cancer patients, and anybody who's involved in GYN oncology knows this about ovarian cancer patients. So this was not a surprise to me at all. So in conclusion, COVID-19, it caused significant disruption in the care of women with GYN cancers. We know this for sure in New York City, and apparently across the country, this is true as well. We had to employ thoughtful considerations regarding treatment modifications based on the little bit of data we know as far as how having cancer, being treated for cancer, impacts your risk for COVID-19. That required looking at the goals of therapy, the risk-benefit ratio, and we had to mitigate the risk of COVID-19 infection and adverse outcomes. Unfortunately, anxiety, depression, cancer worry, they're commonly experienced by ovarian cancer survivors nationally, and the adaptive coping strategies were used more commonly than dysfunctional strategies, and we were happy to see that. So I want to give an opportunity for you all to ask any questions. So I'm going to stop sharing my screen as soon as I figure out how to get up here and do so.
Great. Thank you so much, Dr. Holcomb. That was a great presentation, and you covered a lot of ground. Now we'd like to open it up to the Q&A. So you can still submit questions through the Zoom chat feature, which is at the bottom of your Zoom screen. And then if anyone's watching on Facebook Live, you can also submit questions there in the comment section, and we'll be looking there as well. We'll try to get through all of the submitted questions, but we may not be able to due to time constraints. So while everyone's starting to think of their questions and submit those, we have a few that we compiled in advance and that you all submitted on the registration form. So one question that comes up from your presentation is you talked a lot about how, you know, the changes that have happened in cancer care and treatment as a result of the pandemic. And I'm just wondering if you think that whether any of those changes will remain permanent following the pandemic.
One change I'm pretty confident will remain to the extent that it's allowed by the government is the use of telemedicine. Mm-hmm. And not just specifically for cancer care, but you know, I think once this public health emergency ends, I think there'll be a drive to maintain a lot of what's happened. And for those of you who don't know, telemedicine has been around for years. The reason why you haven't used it before is because we haven't been able to get reimbursed for it, to be perfectly honest. The CMS, the Centers for Medicare, had rules that allowed telemedicine to be used, but they were extremely, extremely narrow. There were very few situations where you'd be able to demonstrate a need for telemedicine. But one of the first things that the government did when the public health emergency started was to broaden those rules to say, no, you guys can use telemedicine pretty much any way you need to. The patient doesn't have to be in the same state you're in, and there were all kinds of things that loosened up. And what I think we realized, we had to start really thinking about our interactions with patients and say, what situations does a physical exam really make a difference? And what situations doesn't it make a difference? Or is it really less likely to be important? And having patients have access to their physicians more openly in situations where the physical exam wasn't critical, I think made us appreciate telemedicine more. And my hope is when this emergency is over, that the CMS will say, this is a benefit to healthcare across the board, and that we'll be able to continue doing this.
Great, thank you. And so we're seeing in the chat, someone's asking a question about whether there's any data relating to the impact of COVID infections on patients specifically taking PARP inhibitors. So it's back to those questions of whether there's differences depending on the type of treatment.
In preparing for this presentation, I thought maybe, because I hadn't gone back and read the literature in a few weeks on this topic, and I thought maybe there would be more on the impact of COVID in cancer patients in general, forget being so specific about PARP inhibitors. And I would say right now, there still isn't a huge, there aren't studies to show that having cancer actually puts you at risk for a worse outcome other than what we saw in China. Well, there's some big differences. One, we have a different strain. Most of the strain that came in, especially through the East Coast, was really coming in from Europe, not from Asia. We have not found that our hospitals have been the major spreader events. It's happening in the community. So I don't think we can necessarily extrapolate everything that we saw in Wuhan to our patient population. Mm-hmm. I do think that immunosuppression, active immunosuppression is likely, if there's anything, that's probably the thing that puts you at risk. So PARP inhibitors can drop your counts. And when you start on a PARP inhibitor, we have you checking your counts monthly to see how you're doing. This is my gut feeling, no one knows for sure, but my guess is if you're taking a PARP inhibitor and your counts are fine, I don't think being on that medication is going to put you at particular risk for a COVID-19 infection over anyone else. But whether it's a PARP inhibitor or chemotherapy, if you're immunosuppressed, I think that's the point where you really have to decide, is this worth it?
Mm-hmm. And then sort of going back, this is sort of along the lines of like avoiding non-essential appointments, but I think this is a really good question. And so what plans are going forward as we enter the second wave of the virus? Should checkups be delayed as they were in March? And I kind of tack on something to that question, which is also that, in the very beginning of the pandemic, when people were maybe avoiding some of their other doctor's offices and getting some of those other routine screenings and treatments, now should people still be avoiding that as well?
So I think you're going to get different guidance based on where you are. I think the burden of COVID-19 in your area is likely going to impact your state's health department's recommendations. And we respond to these rules. We don't come up with them on our own. So New York State was very helpful in being very direct with their guidance when we had to stop seeing when we had to stop doing elective surgeries, and also limiting the percentage of patients we can have in the office at any given time. And it was that granular. It was like you have to go down to 25% capacity, and now at this date you can open up to 50. And it's all tied to the number of new cases you're having in your area and the likelihood of infection in your office because of background infection rates. So right now, I think in preparation, we've been through, at least in New York City, we've been through the height of a pandemic. If we had to switch back to going more heavily to virtual visits, we're prepared to do that. I think our patients are used to it now. Everyone knows how to use Zoom, and not everyone, but a large percentage. So I think we'd be prepared if we had to go back to that. The thing that we don't want to see is that patients delay evaluation of troubling symptoms. I mean, if you have, postmenopausal vaginal bleeding and it hasn't been worked up and you're trying to decide, is it safer to stay home and not have this evaluated? I would say, no, you may have a new uterine cancer. You should come on in. And, we have social distancing in the office, and we have sanitizers, and we are doing all those things to mitigate the risk. If you're in remission and feeling fine, but all of a sudden you have increased abdominal girth and you're having vague abdominal symptoms, should you stay home for fear of COVID? I would say no. You should go in, because you don't want to sit home and the next time you need care, you have a bowel obstruction. and now you're in the hospital. So, I would say going forward, we still need to balance the need to get into the hospital and be seen, but we really are trying to give the message not to delay critical care. And I think we have to message to patients, and it may be new information sometimes, what is critical and what's not critical. I mean, if you're an ovarian cancer patient in remission and you're just showing up for your 3-month CA-125, well, we really don't have evidence that doing that lab test is having an impact on your outcome. So that's going to be one of the earlier things that we drop off.
So it sounds like if it's pressing symptoms or changes, people should really listen to their bodies, but maybe for the other appointments that people should listen to the guidance from their local health departments.
I would say if you have a question and you're not sure, call your physician.
Mm-hmm.
Ask. Don't just not show up for an appointment. Call and ask, I'm having this symptom. Do you think this is worth me coming in? This might be an opportunity for a telemedicine evaluation. And while you can't do a physical exam on a telemedicine visit, there are pieces of information you can get. How much of a distress someone is in. I've done some physical exams on Zoom. Post-op checks when I can say, would you lift up your shirt and I want to see the incisions, and I can pick up an infection on a Zoom call that I don't need you to come in the office for. So I would say when in doubt, call and get further guidance.
Great. And then, so I don't know if you'll be able to speak to this question, but I'll ask it anyway. So we got a question about whether there are different COVID-19 strains on the East and West coasts. And I guess if so, what does that mean?
Yeah, I think the answer to the first one is yes. We do know that the strains from Asia were slightly different than the strains from Europe. What are the clinical implications? I don't know if anyone knows. I think that part is still unknown.
And so this question, it's about so is there any indication that the pandemic is leading to delayed diagnoses of gynecologic cancers?
It's a concern, and we're all concerned, and that's why I was making the plea about showing up if you have a symptom. I haven't seen any studies proving it. Mm-hmm. But the fact that you see in the scale of worry that people were more afraid of COVID-19 than they were of cancer recurrence suggests the potential is definitely there.
Mm-hmm. But you're not seeing, because I know with like in the pandemic when it started and it was getting bad in March and April, that people were coming less for heart attacks. So I was wondering if if you've seen a drop off at all with people coming in with symptoms. Right,
and I haven't seen that in the literature because what you'd have to do is, and I'm sure these data will come out eventually, you'd have to look at stage distribution before and after, before and during the pandemic, and say, well, if in a normal situation 75% of uterine cancer patients present early stage, what happened in April? If you see that it's only 50% were early stage, you'd be able to say, yes, there's evidence that there was a delay in diagnosis. We have stage migration in the wrong direction. I haven't seen any data like that yet.
Mm-hmm. Well, that's good to hear. I hope that means that
to be honest, I haven't seen it because I don't think it's been done yet. I don't know if I haven't seen data saying it hasn't happened.
Mm-hmm. Okay. And then I know that this is on a lot of people's minds when it comes to trying to avoid getting COVID, but are there any ways that people can boost their immunity to try to avoid getting infected?
If you read books, there's all these claims of things you can do to boost your immunity, from meditation to all kinds of things. But as far as proven things to decrease your chances of getting a COVID-19 infection, I would say, no, I don't know anything you can do to boost your immunity in that regard. But the mitigation strategies to decrease your chances of infection are quite clear. Social distancing and washing your hands and wearing a mask, as simple as they sound, One of the things about this whole pandemic that has shocked me is that sometimes you have an answer right in front of you that is just so simple that it seems almost too simple to believe that just wearing masks could prevent, infection or could have such a huge impact. And that's what we're seeing. There's apparently a huge protective benefit, which I think there was a question that was also put in about what mask is better to wear. So maybe I'll just jump. I think it might have been on the list of things you're going to ask.
What mask? So someone asked, what is the best mask? So.
Right. And in the beginning, when we were told we should wear masks and we should wear like just cloth coverings or surgical masks if you're going outside, that was a mitigation strategy to protect your neighbors. It wasn't suggesting that there was a protective impact of wearing a cloth covering to you. It was just so that you would spew out less virus if you were infected. My understanding is that there is some data showing there's a protective benefit of just wearing a cloth mask, but that really wasn't the purpose of that. Whereas an N95 mask or a K95 mask, well, that's a particular respirator mask that has been shown to protect the person who's wearing it. Those are the masks that we wear when we do aerosol producing procedures on patients who are known COVID patients. So I had a patient who was in Florida and she was trying to get back to New York City, and flights had just opened up, and she was asking me, well, what should I do? Should I just wear a mask? And I said, look, if you wear a cloth mask, you're going to be protecting your neighbor. And she said, yeah, a lot of people in my neighborhood aren't wearing masks. And I said, well, if that's the case, you probably should wear an N95 on your way through your trip back, because that's going to protect you and protect your neighbors, whereas the cloth is really just there to protect your neighbors. And you couldn't find N95 masks in the beginning of the pandemic. I know I tried. I live in Brooklyn, and I went to Home Depot, and whereas people who do construction work often wear these masks for construction needs, but they're there now. They're on and I hope that doesn't change, but you can get an N95 mask now. I hear that there's a lot of counterfeit masks on the market, and I don't know how to tell the difference between a real one and a counterfeit one. But I know they're stocked. You can find them again.
Dr. Holcomb, I know you mentioned delays in radiation treatment. For uterine cancer patients who require radiation, how does that work? Because I know it's on a very regular schedule, usually daily.
Yeah. I think, again, you have to prioritize each situation. Because when we sit in tumor board and we have discussions and we may come to the conclusion that somebody needs radiation, there's still levels of priority even within that recommendation. Somebody who's had a uterine sarcoma who has a much higher local recurrence risk than somebody who had a grade 2 endometrioid tumor of her uterus, that we may end up recommending radiation to both of them, but one of them we're much more concerned. And then you even have a situation where there may be women who there's data supporting vaginal brachytherapy alone with just vaginal radiation given on 3 doses and 10 minutes each. And you can find data supporting whole pelvic radiation where she's got to come in 5 days a week for 6 weeks straight. Well, if you're in that overlap where you can justify doing it either way, and you're not sure one's better than the other, and it's the middle of a pandemic, I think the prudent thing to do would be to go towards brachytherapy. So I wish I could just give you a general rule in radiation, but there's so many things that go into us, the strength of our recommendation for radiation. And I think that's really crucial.
So that sounds like very individualized, like you just said.
Yeah, I think that if I was a patient and somebody was recommending radiation, and I think the important thing to know with radiation after uterine cancer, it impacts local control, but there's few situations where we've been able to show it actually impacts overall survival. And so I think you'd want to speak to and this is inside of the pandemic or outside the pandemic. I think it's really important that if somebody's making a recommendation to you, you understand exactly what is the benefit.
Sure.
Not just the risk. Because for you to make an informed decision, you need to be fully informed on both ends.
That makes a lot of sense. Are the current treatments for COVID effective for cancer patients? And what about the vaccine, if and when it's available? Will there be any difference between giving those treatments to cancer patients or non-cancer patients?
Yeah, I don't know if in the vaccine trials that they are specifically looking at cohorts of people with cancer or stratifying by age. The scientifically reasons why you might think somebody who's older might have less of a response to a vaccine. That's surely true in the flu vaccine and other vaccines. But I would think that they would prioritize people who seem to have the highest risk of a COVID-19 bad outcome and make sure they get the vaccine first. I'm speaking of what I think is common sense, but I would think that that would be the process. Once you have a proven safe and effective vaccine, somebody's going to have to put people into buckets of priority. And I would think that elderly and cancer patients would be high up, and I would think healthcare providers would be fairly high up as well.
Sure. Now, I would imagine that you probably have had some patients who were diagnosed with COVID-19, and how did the cancer treatment, how was their cancer, their COVID diagnosis affected?
Yeah, there were a few in that public. I can't say that I had any of, that's not true. I did have one patient. There were a few patients in our trial in that publication of those, the experience of those 3 hospitals. Very few though, so we can't really say much about it. Our hospital said that if you have somebody who's getting chemotherapy and she tests positive for COVID-19, that we should delay that, unless it was urgent, that we should delay that treatment for 2 weeks and allow that person to get over the COVID-19. Because usually by 2 weeks later, you had an idea if somebody was going to have a significant infection or this was likely just going to be mild. We did have a COVID-19 infusion suite set up just in case somebody had to be treated who was positive. But I never sent anybody through that clinic. In most of the cases, it was adjuvant chemotherapy. It was situations where we could take the time to delay until that person was COVID negative.
Okay, thank you. Actually, this is a follow-up question on radiation from somebody who's listening. How much of a window is there for a patient contemplating radiation treatment to delay within the possibility of a second wave of the pandemic in New York? Or, yeah.
Yeah, that's a great question. And I'm going to admit that I would need to go back and look at the literature, because my gut feeling, my memory is that there is data showing that there is a sweet spot after which you start seeing higher rates of what we call local failure, of local recurrences, if you don't institute treatment at a certain time. I would think a rule of thumb would be, getting into treatment within 4 to 6 weeks of the recommendation. But I don't remember exactly when you start seeing increased risk of recurrence. I'd have to look into it. But I think it's an excellent question to pose to the person who's recommending the radiation to you.
Yes, no, that sounds very good. I think we might have one more question. Actually, no, we'll do 2 more. And you may have touched on this before, but I just want to make sure, with the COVID-19 pandemic continuing to worsen throughout the United States, do you foresee any further changes to cancer care and treatment in the upcoming months?
So we had this experience. I'm praying that nobody has an experience like New York City did. And so far, no city has. I mean, but you see the numbers going up, but if you look at the number of deaths in these cities and the number of infections, we still had the worst experience so far. Our numbers right now are fortunately low. So I think the changes that may happen is that other cities may have to do the things that we went through earlier in the spring. So I kind of think we've been through the worst. We had to shut down completely. And I think a lot of places haven't. But I think what you're going to find is, unfortunately, the New York experience being repeated in the upper Midwest and, the West and in the Southwest and places like that that didn't see it in the spring.
Right. I think this is going to be the last question, and this is a very good one, actually. And this came from somebody in the chat. As a recently declared no evidence of disease cancer patient, am I still a current cancer patient? Are they still considered to be?
When you say no evidence of disease, I'm assuming the person means I did everything that was put out in front of me and I completed my last therapy. And I would say, one, congratulations. And two, no, you should consider yourself that I had a cervical cancer, I had ovarian cancer. Because at that point, you've completed therapy and you have no evidence of disease. And so, no, everything I'm saying about somebody under active treatment, that doesn't include you anymore. And again, while we're still early in this pandemic and we're in a learning phase, it does appear that it's active immunosuppression that's the concern. Now, I've seen some patients who finished their 6th cycle of chemotherapy after advanced ovarian cancer, per se, and then their counts are still low. It's cumulative bone marrow toxicity, and they're not going to go back down because you're not giving them any more chemo, but they may still be on their way back up to normal. Well, you may have no evidence of disease, but you might still be in a period of relative immunosuppression and at risk during that time. So I'm not sure what the questioner was getting at, but if you're saying, do I have to be concerned? I would say it has more to do with the status of your immune system, in my opinion, than whether you have evidence of disease or not.
That makes a lot of sense. And I think all of this points to what you were saying before, that in these cases, to always consult with your gynecologic oncologist, because every situation is really different.
Yes, I think that is important.
Yeah, so I think we're going to wrap up. So thank you so much, Dr. Holcomb, for this really interesting program.
And thank you for hosting something like this, because I think it's such a service to get out. I mean, it's an area that there's not a lot of definitive answers, but at least an opportunity to pass on what we do know.
Yeah, it's terrific. We really appreciate it. And thank you to the audience also for participating and submitting questions. We are going to send a program survey by email. So when you get that, please take a moment to fill it out. And I want to wish everyone a very good weekend and